Hello and welcome to JAMA Health Forum Conversations. I'm Dr. Sandro Galea. I serve as Dean of the School of Public Health at Washington University in St. Louis. I also serve as Editor-in-Chief of JAMA Health Forum, a peer-reviewed open-access online journal focused on health policy, healthcare systems, and population health, one of 12 specialty journals in the JAMA network. It is a time of progress and challenge for LGBTQ plus health. In 2015, the U.S. Supreme Court ruled in favor of same-sex marriage, a decision that was codified into law in 2022 in the Bipartisan Respect for Marriage Act. This long overdue progress acknowledged the fundamental dignity of this population and opened the door for LGBTQ persons to have wider access to health insurance and healthcare services. In the 2020 Bostock v. Clayton County decision, the Supreme Court ruled that transgender persons are covered under the workplace non-discrimination provision of the 1964 Civil Rights Act. These gains have emerged from a context of increased acceptance and visibility for LGBTQ plus persons. Yet, there have also been setbacks for LGBTQ plus rights. The current administration has ended recognition of gender identity in federal context and overseen a rollback of resources dedicated to LGBTQ plus care, including millions of dollars in grants for improving the health of this population. The conversation about gender-affirming care for transgender-identifying youth has become politicized, generating more heat than light and threatening the health of a vulnerable population. With all this in view, it seems more important than ever to protect the dignity and health of LGBTQ plus persons in this complex moment. Here to discuss how we can do so is Gilbert Gonzales. Dr. Gonzales is an associate professor in the Department of Medicine, Health and Society, the Program for Public Policy Studies, and Department of Health Policy at Vanderbilt University. He also serves as the associate director for the Vanderbilt LGBTQ Plus Policy Lab. His research explores how public policy shapes health outcomes for LGBTQ plus populations. His work has been covered by a range of news outlets, including CNN, Reuters, New York Post, Guardian, U.S. News and World Report. In 2016, he received the Chancellor's Award for his research on LGBTQ plus health at Vanderbilt. I'm delighted to be speaking with him today. Gilbert, welcome.
Thank you.
So let's start from the beginning. Can you sketch a little bit the state of LGBTQ plus health at this moment? Where do we see progress? Where do you see challenges?
Well, I just want to step back for a minute and think about where we are in the historical trajectory of LGBTQ health. In the 80s, we got HIV research, STI research. In the 90s, we grew in mental health and psychological research on LGBTQ people, where we started understanding the nuances on what's driving higher rates of anxiety, depression, psychological disorders. Right now, we are really thriving in everything else, everything from cancer and cardiovascular disease, access to care, and just overall well-being for LGBTQ health. And the science around LGBTQ health broadly has grown a lot in these last 20 years during the beginning of this century. And there's been a lot of progress made, including data collection efforts that have added sexual orientation and gender identity to big national data sets that we use. There's been a growth in not just junior researchers, but those junior researchers have begun to age, are now thriving in mid-career. And we now have a robust mid-career and senior level faculty who are able to train LGBTQ health researchers and the future of LGBTQ health researchers. For instance, when I was a PhD student, I didn't necessarily have someone in LGBTQ health to mentor me in the science of it, but now we have that. So I would say on the big picture, it's thriving. It has grown, it's here, and it is a big part of public health and medicine now. But there are challenges. I would say that there are concerns around real-time data collection on sexual orientation and gender identity in big data sets. And funding continues to remain a big issue, especially as administrative priorities change in Washington, D.C.
I like how you started by framing this in the positive, because I agree with you. I think we've made enormous progress in the past 25 years, and that's important to ground. Let's talk a little bit about your work for a second, because you work at the intersection of LGBTQ health and policy, and there are relatively few people who do that in the country. Talk us through key questions in terms of policy in LGBTQ health right now.
So when I started this, and I've been faculty here for 10 years at Vanderbilt, when I started, we were still debating marriage equality and same-sex marriage, or some people call it gay marriage. And that's what my early research was on, was like, what are we doing? And what does the science and evidence say around gay marriage? And we didn't have great data, but we were trying our best to use secondary data sources to answer those questions. And a lot of us have been focusing specifically on LGBT targeted policies and how they impact health or shape health disparities for LGBTQ people. Some of those policies have been on same-sex marriage. Others have been on non-discrimination protections and living in a state that has what we call an Equality Act, meaning that discrimination is banned based on sexual orientation and gender identity in the workplace, in schools, in public spaces like hotels or trains and planes. But we've been focusing more on those policies. And in more recent years, what's kept a lot of us busy has been on transgender specific health policies, those that may be affecting their access to medical care or access to sports or driver's license that matches their current gender identity rather than the sex that they were assigned at birth.
Do you think there's any particular policy area that has a disproportionate influence on the health of LGBTQ populations that is understudied?
I think what's happening is that a lot of the focus, at least in the last 10 years, on LGBT specific policies has been on same sex marriage or gay marriage, marriage equality. And we took advantage of those states doing it one at a time to do what we call quasi experimental designs. And some really good research has shown that marriage equality has improved health insurance rates and access to care for sexual minorities. And there are some nuances there, but the research has consistently shown improvements in health insurance and access to care for sexual minorities. The research on mental health improvements has been mixed. Some studies say, look, there's also a mental health advantage for when gay people can get married in these states. They may be more accepted, stigma may be less, but other studies don't always find that same finding.
Let me go to an area of your work. You've used a lot of census data in your work. Can you lead us through? I have two questions here. Number one is what you've actually done in your work. And number two, can you tie it into the moment when we're seeing a number of threats to census, the way census is collected, and really to a number of other data sets that some used to be available, some are not available. What impact is that having on your work and the work of people in the field?
Yes. So for the census data, whether it's the decennial census that happens every 10 years or every year when we do the American Community Survey, we get information on 3 million people every year. Like most countries, we don't ask sexual orientation or gender identity. So some of my work has looked at the household roster. Who is living in the home in the census and how are they related to each other? So we can identify same-sex couples. Married same-sex couples are those who may be in a cohabiting relationship because they say that they are either married, they're identifying their same-sex husband, wife, or spouse. And a lot of us early on were using this when sexual orientation was not being collected. And we were beginning to understand health insurance rates or income and unemployment disparities. I think this is a good lesson for now when data are being scrubbed of sexual orientation or gender identity. And we can talk more about this, but as data are being taken away when collecting sexual orientation, or there's hesitancy with adding sexual orientation to the census or to other census data sets, we can still do high quality research on same-sex couples. Yes, we're missing single LGBT people who may not be in a relationship. We're missing those who might not be living in a home, but we can do some really good work on same-sex couples and understand their health, well-being, and overall life.
Let me build on it a little bit. And this is a bit of a chicken and egg question, I realize. How much does progress on LGBTQ health drive the collection of health data? And conversely, how much does the collection of these data drive progress?
Well, I think that LGBTQ rights is driving data collection rather than the other way around. If data collection were driving rights, we would be in a very different world. We would be in a very different world if that were the case. We would have equity in many ways because of the data. Say, look at these data, look how bad things are. Let's make a change and fix these wrongs. But I think it's the other way around. I think LGBTQ rights and the movement and a just broader understanding of LGBTQ people and the issues around sexual orientation, gender identity, and politics and policy is influencing better data collection because people are saying, hey, what about me? You're not counting me. I'm not seeing myself in these data sets. So we begin to add sexual orientation and gender identity to big data sets, big surveys that are done either by the US Census Bureau or the CDC. And that helps inform the research that eventually feeds back into some of the rights, discussions, and policy debates.
You know, your answer is a really beautiful answer about sometimes how difficult it is to separate out social conversations, value conversations from data empiric observations. And, I've often reflected in some of my own writing about the fact that our job in population health, scholarship, and science is to be cognizant of both, right? To make sure we generate dispassionate data, but at the same time to engage in the public conversation. And recognizing that both those matter is critical to what we do. And I think your answer in this field captured that so well. Let me ask a slightly different question, if I may. Let's talk a little bit about the state of the country in terms of the federal government and the state. Do you see federalism as a net positive or net negative for policies that affect LGBTQ health? And to what extent should such policies be decided at the state level, and to what extent should they be determined by the federal government?
So I'm going to speak for Gilbert for a minute, and I don't always believe in black and white answers. I don't think that federalism has a net positive or net negative effect. It can be both at the same time for different people. It can sometimes be a net positive, sometimes a net negative. But the way I see federalism working for LGBTQ health, I think of it like Justice Louis Brandeis would describe it, as federalism as being our laboratories of democracy. And if one state wants to try something, let them and see if it works. And if it works and it leads to improved health outcomes of a net benefit, then let other states do the scientific thing and replicate it. And that's the way I view federalism, as a laboratory of democracy. Let's try different things and let's see what works, what doesn't work. And then if something is working right, let other states do it. But if we're using this analogy in laboratories, we're taught to also do no harm. And I think that we need to sometimes remind ourselves about that policies, when they are making these state level decisions and policy, we need to keep in mind that policy should do no harm. I personally believe that public policy is an intervention for population health. It can be. And when a policy is working at the state level and is causing more good than harm, then let's replicate it in other places and see what happens. If it's not causing enough good harm, for instance, so let's say in terms of marriage equality, all 50 states have marriage equality, but health disparities haven't gone away. So let's think about that policy as a population health intervention. Maybe the dosage in that policy isn't high enough. So let's ramp it up. Let's increase that policy a little bit for a net benefit in LGBTQ health. And that might look like banning discrimination in employment and in schools and in public spaces, which some of my work has shown has led to even better improvements in health. And so federalism, I think, works great. Let states try different things. But if it's a laboratory of democracy, we need to stand with like what all physicians and scientists are taught from the beginning: do no harm.
I really like your emphasis on nuance around something that I often feel in the public conversation is portrayed with a unhelpful broad brush. So thank you. Let me push a little bit on research for a second. If you were to list top 3 areas of understudied areas at the intersection of policy, LGBTQ health, what would they be?
Number 1 is transgender health and gender minority health. I think the research has not kept pace with the transgender rights movement. And I think there's still a lot to learn about trans health in terms on, what are the major disparities? And for some people, it might be access to care, access to medical care. Before we even talk about gender affirming care, but just like access to medical care, can they afford it? Can they find a doctor that is gender affirming? But I think in the research space, number 1 is trans health. Number 2 will probably be just more like the social determinants of health in terms of LGBTQ health. We know a lot about what's working in medicine and what public health research has documented, but what about like just everyday stressors and work and schools? How are people relating to each other? How are people coming out again and again in work or at church or in schools? But I think just understanding the social determinants of health is still definitely an understudied area. It's probably because those of us who are in medicine or in health policy, which is my discipline, hasn't always focused on that. And lastly, global health. I think the world is ready to start doing more LGBTQ health research at a global scale. The countries that are doing it well right now are the United States, Canada, and parts of Europe. So the global South is now starting to experiment with adding sexual orientation to their health surveys. I imagine that many, many more countries will be joining that soon. So I think the global South is primed for LGBTQ health and is ready. And I hope that this next wave will be more inclusive of international comparisons.
Let me talk a little bit about the number 1 area you identified, because I do think it's important. I agree with you. I think it's a real area where we need a lot more work. So, much of the current public conversation also has focused on transgender persons. So summarize for us, where do you think is the state of the public conversation in 2025? And to what extent has the public conversation engaged with the complexity of the topic versus politics and forces of backlash, perhaps causing us to go astray?
Well, I think that the discussions have definitely outpaced some of what we know in science. And people have very strong opinions about this. And that's just part of human diversity. People have different opinions and attitudes. And I think what we see today with some of the backlash for LGBTQ rights might be because some people really connect and resonate with it. Almost 70% of Americans are okay with same sex marriage or gay marriage. 70% of Americans are okay with gay marriage. So these are according to Gallup polls, and they're not always perfect or great. But 70% of Americans are also not okay with transgender athletes participating in sports based off their current identity. But almost two-thirds of Americans think that trans athletes should compete in sports based off of their sex assigned at birth. Or 70% of two-thirds of Americans think that transgender people should have a driver's license that matches their sex assigned at birth. And so I think some of the rights movement, an important role for that might just be to educating and teaching people who transgender Americans really are, rather than what politicians and social media or influencers might be saying they are.
That really resonates with me. It feels to me that most people, most of the time, have the best intentions of their neighbors at heart, and most people, most of the time, want to do the right thing. And I appreciate how you say that there is a diversity of perspectives. It is part of human nature. It is the part of the wonder, beauty, and challenge of being humans is that we may disagree on things. Now, there's no question, I think, to anybody paying attention to the public conversation that there are bad faith actors who have used these issues to bring about divisions. So recognizing that, but moving beyond that, what do you think are key elements to encouraging a nuanced, thoughtful public conversation that recognizes that different people with very coherent worldviews may feel differently than others with different coherent worldviews in a way that we can actually advance a complex conversation, create space for research, and make sure that the public conversation catches up with the scientific conversation?
Honestly, if I knew the answer, I would share it. I think we're all trying to figure that out right now. I don't know if we know the answer to that, not just in LGBTQ health and equity, but with just global issues and problems broadly. I don't know if we know the answer to that. What I've learned as a professor, and I teach undergraduates, so 18 to 22-year-olds who are exploring different ideas, different topics, what I've seen work, and they come to class from all different backgrounds, both here in the country and around the world, different upbringings, different beliefs. And the ways that we're able to have really complicated discussions in the classroom is to begin with just respect. We're not going to yell at each other. We're not going to call each other names, but we're going to start with some ground rules that begins with respect for human thought and difference, and that we may leave the room disagreeing, and that's okay. But let's at least get some ground rules. And also, one of those ground rules that tends to come up is let's just agree on some solid facts, and we put them on the board. And we talk and like, what is this fact that we're going to agree with? And, where did it come from? And we're going to start there. And then we build a robust conversation where there are differences. And sometimes they're very difficult conversations to have. But I think that's something that, at least in my classroom, I'm seeing that I hope that they go out and spread that to the world.
Well, you started answering my question by saying you did not know the answer, but I thought that was a pretty terrific answer. So thank you. We are living in a moment where this area of your scholarship is really at the white hot center of some of the current cultural contradictions, right? It's 2022, Respect for Marriage Act passed, bipartisan support.
Yep.
The Bostock Supreme Court decision ruled the Civil Rights Act covers transgender persons. That majority decision was written by Neil Gorsuch, who's a Republican appointed justice. In the 2024 election, Republican Party removed opposition to same-sex marriage from its platform, and President Trump has appointed many well-known gay and lesbian persons to his administration. So it's a bit of a paradox in this moment that there seems to be a significant shift towards an acknowledgement of LGBTQ rights at the same time as there seems to be a rollback of policies that support the health of LGBT populations. So what do you make of this contradiction?
Yes. And so I started out our conversation with, how LGBTQ health has grown as a subdiscipline in medicine and public health and is pretty robust and is continuing to grow. But what I've seen is that usually in terms of LGBTQ health and rights, from what I've seen is that there's usually 2 steps forward and 1 step back. And I think right now we are in a period of retrenchment where LGBTQ rights felt like they are being attacked rather than expanded broadly. And so you brought up some Supreme Court cases like Bostock v. I believe Clayton County, enshrining and banning discrimination based off of gender identity. But there are still cases going to the Supreme Court this year that will be impacting LGBTQ health. And one is on what some people may call conversion therapy. And a therapist in Colorado has sued the state, which banned conversion therapy for minors, meaning that therapist cannot try to change a person to be straight or heterosexual or cisgender. And a therapist has sued the state, and this has made its way to the court, where the court will decide on whether banning conversion therapy, and that's been done in a dozen or so states, whether banning conversion therapy is allowable under the Constitution. And so with the makeup of the court, as it has changed, and since some of these previous cases, the makeup of the court has changed. Anthony Kennedy and Stephen Breyer have retired, and the passing of Ruth Bader Ginsburg has led to a more conservative Supreme Court. So I'm not sure where this is going to land in terms of this therapist's right on providing conversion therapy. And what we know from the science is that conversion therapy, A, generally does not work, and B, can actually cause a lot of harm to an LGBTQ person when forcing them to be straight or cisgender and denying their sexual orientation or gender identity. But this is just one case. The other one has to do with transgender athletes and sports participation in schools. And so I think we are in a period of retrenchment. But in terms of the conversion therapy case, I am hoping that medical practice and science will win and allow states to continue supporting medical guidelines and best practices and banning conversion therapy because it can cause more harm than good.
There is in the moment a disinvestment from research grants on LGBT issues, particularly from NIH. How are you meeting the moment, and how is the entire health policy community supporting the next generation of scholars to make sure that we do not lose a generation as we get through this period?
I think it's difficult. So at Vanderbilt, we were part of a team that lost 3 R01s that were on LGBTQ health. And so that was a total of some $9 million over the next 5 years. And so this is close to home. We lost NIH grants that would study best practices in preventing LGBTQ youth suicide prevention, that would further study gay marriage or same-sex marriage in global context, and would study older LGBTQ adult health. They have since been reinstated at varying levels of funding. So not the full funding that we were once promised, but they have been reinstated. So this has hit close to home for me. What I will say is that it is discouraging, and I think it has already had a chilling effect on junior scholars, those who may be junior faculty or PhD students or postdocs who are going in the space. They are worried about their futures and receiving funding from the NIH, which in the last 20 years has helped build the discipline that I described earlier, the field of LGBTQ health that I described earlier. So many of us are worried about the future of the field, but we're doing our best to train junior folks and ways to do it without relying solely on federal funding. And so what types of work can we do at the community level with community partners or with industry?
Let's end on hope. What gives you hope at the moment?
What gives me hope are just the goodness in people. I fundamentally believe that people are good. And we see a lot of LGBTQ health disparities. We see some of the bad things in the data set, but there's a lot of good things happening too. A lot of people are finding support from their friends, their family, their neighbors. Not everybody, but a lot of people do. And when they do find that support, it translates to better health and well-being for those LGBTQ Americans. There's a lot of really good-hearted doctors out there. That's what they go in the field for, to help others. And, for when I talk to some providers here and around Tennessee, they tell me that, Gilbert, I really want to be a good person with an LGBTQ patient. I just don't know how to talk to them sometimes. I'm like, don't worry about it. We've got some continuing education that can catch you up on some of the language to use and ways to approach LGBTQ health. But it's just like knowing that there are really good people in the world keeps me going.
That answer is plenty to keep me going, and I think many others who are listening to this, thank you. I'm Sandro Galea. I've been speaking with Dr. Gilbert Gonzales, and we've been talking about LGBTQ health and how it intersects with the moment. You can find a link to articles by Gilbert and by myself on this topic in the episode's description. Gilbert, thank you for talking. Thank you for everything you do.
Thank you. Thanks for having me.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com, jamahealthforum.com, or look for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.